Our next presenter is Garrett Black, Senior Vice President of Health Collaboration and Provider Relations at BCBS, Minnesota.
Good morning, everyone. I see some familiar faces in the audience. That's good. Thank you for having me today. My presentation is going to be about the power of collaboration to drive innovation in healthcare. And the example I'm going to be using is collaboration with the Mayo Clinic. But I'm going to start off with talking to you all about my journey as a healthcare leader. So at Blue Cross and Blue Shield of Minnesota, I have responsibility for healthcare value. Now, healthcare value is making it more affordable, improving the quality and the experience. And as a leader in healthcare, whether you're in a health plan or a care delivery organization, there are a series of challenges that you have to start grappling with. Healthcare today is largely transactional, whether you're delivering the service or paying for the service. It costs too much, and most of the focus is on what we pay. A little bit of focus is on how we pay. The complexity is overwhelming. It's overwhelming for the people who are receiving health care, it's overwhelming for the people delivering health care, and it's overwhelming for the people paying for health care. A lot of the actors are uninformed or partially informed because we see different perspectives or we play a different part in this transactional system. And ultimately, it's a very reactionary system. Sick people present, they get treated, a bill shows up at the insurance company pays it. So as a leader, when you face these challenges, or when I face these challenges, I started to work on a solution set, creating accountable care organizations, medical homes, creating value-based payment models, and I've been working on that for 5 years. And what I had to ask myself about a year ago was, are all of those initiatives really going to lead to something exceptional in the healthcare system? Can it make healthcare more relational, less transactional? How do we start talking about value in different ways besides cost? Because the amount of time that it takes to work in the healthcare system is another value measure. Or what about the experience of a member, of a patient? Or what about balancing cost and quality? How can we make the whole system simpler for everybody to understand? How can we empower patients around what their options are, their decision points? And how can we become more proactive? And I asked myself, are the current solution sets, accountable care organizations, medical homes, value-based payment arrangements, are they adequate? And from my perspective, the answer is no. Now, they are very laudable, and they are showing progress in reducing cost and improving quality. But the fact of the matter is, for Blue Cross Blue Shield of Minnesota, less than 1% of all our payments to physicians and hospitals are tied to a value-based payment. That's after 5 years of work. So I decided that this is just way too slow and way too incremental, and it's not really all that innovative. That if we want to get to an exceptional healthcare system, we've got to find a different way. And so I became convinced that I needed to do something different. And I also had a hunch that the best way to do this was to start collaborating with providers in a very different way around, let's not settle for incremental improvement in the healthcare system. Let's try to create some breakthrough innovations. And through multiple discussions with providers, eventually a framework emerged. And the framework is fairly straightforward. The first question I had to ask physicians and hospitals was whether or not they were interested in trying to move to this notion of exceptional health and deal with all the challenges in a very different way. The next question in the discussion was, well, what are your unique abilities? What can you uniquely bring to the table from a care delivery standpoint, or maybe from a care coordination standpoint, that would truly make healthcare exceptional? And we would come up with ideas, and then we had to ask and figure out, could we really bring this to the marketplace? How would we create a product around this, or how would we monetize this? Because we're all prisoners of the fee-for-service system at some level. I mean, that's how healthcare is paid for. So we have to figure out different ways to bring these products to market, especially for self-insured customers who buy their insurance through Blue Cross. Does it really create something that's exceptional? Is there a better experience? Is there a better value? And after we've gone through all those questions, does it really make a difference? Does it make a difference at the individual level or at the community level? And this was the framework that was used to collaborate with the Mayo Clinic to create an innovative program that I'm going to share with you today. The setup for this is, I want you to meet Sonia. Sonia's situation is that she's the mother of 3 children. She's the breadwinner of her family. She's been a diabetic for many years, and she has recently been told that she has end-stage renal disease, kidney failure. Now, for Sonia, just hearing this, she's starting to learn about end-stage renal disease, and that the treatment for end-stage renal disease is a kidney transplant. So Sonia is starting to learn some hard truths about this, that there is a shortage of donors across the country. And because there's such a shortage, she will have to go on dialysis. Now, the average time on dialysis for someone who has end-stage renal disease is 2.9 years. That's 3 to 4 times a week. Now, for Sonia, how is she feeling right now? She's scared. She's probably very anxious. Will she find a donor? How is she going to continue to be the breadwinner of her family? Does she have to go on partial disability? Does she have all the information to be able to make choices about her life, about her care decisions? So she's got a lot of anxiety and complexity in her life right now. Now, as a healthcare leader, what Sonia is facing is she has this diagnosis of end-stage renal disease, and she is going to have lots of interactions with the healthcare system. Dialysis center, specialists, hospital. Now, Sonia sees gray dots. Sonia doesn't know the relative quality of these interactions. She doesn't know the relative cost of these interactions. But as a leader at Blue Cross, I know that these dots are not gray. I know that there's a big difference in the cost and the quality along all of these decision points that she is going to hit. And I hope, for Sonia's benefit, that she hits all blue dots. But if she happens to hit one or more red dots, which are bad interactions with the healthcare system, low quality, high cost, bad experience, if she doesn't get guided, she's going to end up with a higher cost of care, maybe not the best outcome, frustration and a bad experience, or multiples of this. And so the question is, who? Who is going to guide Sonia and inform her of her choices? Who is going to color the dots? And how do we even begin to identify what the best choices are? And that's where the collaboration with the Mayo Clinic came into place. So there have been collaborative discussions between Blue Cross and the Mayo Clinic for over a year, and we used that framework that I talked about. We asked the Mayo Clinic, give us some examples of what you are really good at. and one of the programs that I knew nothing about was the Living Donor Kidney Transplant Program at the Mayo Clinic. And we started to look at that program, but we decided that whatever we focused on had to meet some basic criterion. We had to prove that it had the best health outcomes. We had to show how it could impact the cost of health care. We wanted it to impact the patient and the family's health. And we also knew that because so many of Blue Cross customers are self-insured, that we had to figure out how would we go to market together with a program like this. And so that work is where that design and work really formed up this partnership around living donor kidney transplant. And so the concept here is we, together, the Mayo Clinic and Blue Cross Blue Shield of Minnesota, we are going to create guidance for Sonia to the Mayo Clinic. And so what this involves is we want to help Sonia avoid the red dots, which involves we have to identify the Sonias, we have to get her referral to the Mayo Clinic, she gets her transplant and follow up, and she has a better outcome. Now I want to talk to you about the outcome, superior outcomes. So the Mayo Clinic's transplant program is unique. Most of the transplants done at Mayo, 79% of them, come from living donors. 34% of other transplant programs are living donor. The majority of the other transplant centers are from deceased donors. Mayo's clinical outcomes, because of the living kidney donor program, are superior. Much higher success rates of the graft and much higher long-term survival rates for the patient. We also looked at the cost of care. Now, what we want to do is we want to have Sonia avoid dialysis altogether. The average cost of a Blue Cross member on dialysis for 2.9 years is $662,000. That's not counting the transplant or any other care. That's just the dialysis treatment cost. So we can avoid all or some of that dialysis cost if we can route Sonia to the Mayo Clinic and if we can find a match for her. The other way we can express value here is we have created a prospective package price around the transplant, which is 21% cheaper than other options in the Blue Cross network. And the other thing we wanted to do is we wanted to have a singular patient experience. So when Sonia is being navigated, she has to deal with one team that can help her understand her benefits and coordinate her care. So there's one experience. She doesn't have to deal with Blue Cross separately from the Mayo Clinic. So the program we've designed is really to meet these needs around how can we make a difference and guide our members to their best option for particular complex clinical conditions. So let's go back to Sonia. She's still the same person, and she has the same responsibilities and obligations in her life. She's still a mother. She's still the primary breadwinner. But she knows what her choices are, what her options are. Because we have engaged Sonia when she was a diabetic and when she was nearing end-stage renal disease. So she's more secure in knowing that there is an option or an alternative for her instead of years of waiting on dialysis. She's also more educated on her options and choices. And she has people that are waiting for her to help navigate and guide her through her experience. From the employer and health plan perspective, the employer's retained a valuable employee. They have lower, more predictable health care costs. We can show and prove that Sonia will get the highest quality of care and the best outcomes. and that she has a coordinated experience. And ultimately, we want to make Sonia a very satisfied member in person. So when I think about how we drive value in healthcare, it's got to be through collaboration. Because we can't create breakthrough programs alone at Blue Cross and Blue Shield. Providers can't create breakthrough programs alone, or at least they might be able to, but they'd have limited market reach and impact alone. So for me as a healthcare leader, I believe that this is the future of healthcare. Deep collaboration between all the stakeholders. This would not have happened without leadership from the Mayo Clinic in that spirit of collaboration. So I really do want to recognize a few people here that I know are in the audience. Dr. Charles Rosen, Michael Troska, Tracy Daly, Steve Knutson. They were the co-authors and co-collaborators of this partnership for the Living Donor Kidney Transplant Program. And we spent many hours together learning about each other, learning about our businesses, talking about how do we create breakthrough value in healthcare, learning how to productize this, going out and talking to employers about it, because we have enrolled 5 of our largest employers in this program, because it's in proof of concept. So they were with us shoulder to shoulder when we went and portrayed the value proposition to some of Blue Cross's largest customers. So what I would encourage everyone here to do at some point in their career is try to step away from your existing business model and try to collaborate with whoever you think can drive unique value in healthcare. Thank you very much.
So there's always a lot of interest in the Blue Cross Blue Shield guy at this conference.
Especially the day after rates are released.
Yes, especially. No, and there were some references to that. Would you ever reveal your negotiated medication prices? Make that public knowledge?
Yes.
You would?
Yeah.
It's not your call, though, right?
Well, it's a question of, I think it is my call, actually. You know, this transparency, I believe transparency is very important in healthcare. It gets back to, you know, not everyone is an informed actor. So I think there's a question of how you actually get this information to patients, members, when they need it at the point of care. We have transparency tools today, and they do show the cost of healthcare, but it's for a limited set of services, and it's, you know, it's on a website. I think it has to get a lot easier for people to understand healthcare costs at the point of care, but also the total cost of a course of therapy.
How is the renal example that you described different from the centers of excellence models that have been operating for a decade or so?
I don't think it's radically different. I think what's different is that, you know, a center of excellence designation is typically done onto a hospital or a provider, where there are people that look at cost, quality, and they make some sort of judgment call. That's not how we did this. We actually started with no preconceived notions of where the value was, and we just let the process lead us to where can we uniquely create value in healthcare, and we proved it out by looking at quality and cost.
Although, wouldn't the value have better come from a program with Mayo to have prevented Sonia from getting the end-stage renal disease to begin with?
Yes, we want to go upstream as far as we can to try and do preemptive transplant.
And are you working with Mayo to try to do that?
Yes. Yeah, we're in proof of concept right now with 5 employers, and a big part of the proof of concept is how and when can we identify and start to educate these patients before they're at the point of needing dialysis.
Someone here who had experience with Blue Cross Blue Shield says that it all sounds good in theory, but in contacting Blue Cross Blue Shield, there was no interest on their part on outcomes of disease. Their only interest was cost. Our innovations and outcomes data were ignored. How will you implement such ideas at levels of the organization that matter in the real decision making? Now, I don't know what kind of player is being referred there, but if you could elaborate on that.
Yeah. So Health Collaboration is a startup within Blue Cross. And the majority of Blue Cross's work is still focused on negotiating price. It's transactional. So as a leader, I decided to create this focused area so we could pursue true collaboration where we can start to bring in domains of let's pay for value and quality in a different way.
So you're the nice guys within the organization, and the rest of the organization is not caught up to what you're doing, or?
I have both hats, actually. I have the black hat and the white hat.
I see. Is there a strategic conversation underway to expand what you're doing at a smaller scale to the entire enterprise?
Yes. We intend to grow and expand our health collaboration efforts to work with more providers, more physicians, and more hospitals around these sorts of innovative programs and expand them.
What do you think of the idea of patients being very much involved in their own care and in their own understanding of the bills that they're paying and being involved in preventive health arrangements with providers like Blue Cross Blue Shield? Do you have bandwidth for that sort of thing, or do you think that's something for the accolades of the world to deal with their health assistance?
No, we believe that's an important part of the capabilities we need to develop. So we're launching a care advocacy program. The care advocacy program is where we take a customer service team and a health coach team and we put them together so we can help people guide and navigate and understand their healthcare choices, both from a care and cost perspective. So I think consumerism is the future of healthcare. What we have to do is we have to use simple, smart systems to make it easy, relevant, and personal for an individual.
Do I want to be paying, I mean, if someone is saving my life here at Mayo, do I want to be paying them or do I want to be paying you? In other words, is my experience and my understanding of the healthcare system going to be improved by paying you, who are not a doctor, a perfectly nice fellow in a blue suit, as am I, or should it be in paying the people who are actually delivering the service?
I guess I don't make a distinction between who or how it gets paid. The distinction I go to is the value, are people getting to their best care point for the payment? And so there is so much variation in healthcare from an experience, a cost, and a quality standpoint that I think it's really not about payment. It's about, based on my particular situation and condition, am I getting to the best fit provider for my needs?
Well, just talking about the outcome and the consumer experience and the idea that if the consumer has a good experience, that they're going to then do it again, or they're going to not fear the experience and so tolerate things that will result in worse healthcare scenarios. When I have that good experience, the payment is the place where me as a consumer is able to deliver the message, thanks so much for helping me out. Now, if you're in the middle of that transaction, I don't necessarily get that experience of thanking, essentially giving the gratitude chip to the person who is actually involved in my care. It becomes a kind of faceless bureaucracy. Or you could be that. You could be the nice insurance person who, sort of coached my way through this complicated system, but it's got to be somebody. It can't be nobody, right?
Correct.
And so would you prefer that it's an insurer, or would you prefer that it's the actual medical provider from the consumer standpoint?
Well, I think the insurer place in the healthcare ecosystem is around the aggregation of information, navigation, and the balancing out of risk. And so that's been the traditional and value proposition of the insurer. What insurers need to do a better job of is helping individual consumers navigate the system and partnering with providers to drive value in healthcare. The transactional payment-driven system that we're living under today is not the system that's going to be sustained into the future. And so whether you shift the point of payment or the transactional support of payment around, I don't think that makes any difference. I think until we actually get to a consumer-driven healthcare economy, that's what's going to drive the biggest change in the healthcare system.
So I need to feel like whoever it is that I'm paying is helping to take care of me, as opposed to being just a return address on an envelope.
Correct.
All right. What's the healthcare outcome short of fatality that you most want to fix tomorrow? The thing that happens to consumers that is most frustrating to them that you wish you could fix tomorrow?
To make it personal and relational. I think whether you are dealing with the insurance side or the care delivery side, it's so hard to have a relationship with the people that you're seeking care from. And there are so many barriers in the transactional system to that. I would love it so consumers could, at any time, connect with their caregivers and have the information at their fingertips. That's what I would love to solve most.
Why can't they do that?
Well, because it's typically, if you want to see your doctor, you have to schedule an appointment, because that's how doctors get paid. It's not, most doctors don't have access to their patients through text. Some have it through email. It's this transactional system gets in the way of kind of a true consumer-centric approach to delivering the service.
Have you heard anything here in the conversation, I don't know how long you've been around, that excites you?
What excites me about what I'm hearing is that there are a lot of people that are trying to step outside of the traditional thinking and business models that they're being asked to either be a caregiver within or a leader of. And that's why I'm such a big believer in collaboration. Collaboration requires that you work with people that you wouldn't naturally work with. And so for Blue Cross to go out and show up and have a conversation with providers that today we're not going to talk about payment. Today we're not going to talk about how we pay or what we pay. We're going to talk about how we can make the healthcare system better. And what unique ideas or approaches do you have that you would like to work with us on to bring to the market? That's the sort of behavior that we need to encourage in healthcare. People stepping outside of their boundaries, learning each other's languages, and starting to collaborate in a very different way.
So that keeps it Blue Shield, Blue Cross Blue Shield, rather than Black and Blue Cross, Black and Blue Shield, right? Thank you very much, Garrett.
You're welcome.
It's great.